Good morning and good evening to Dr. Kirsten Small, and good morning to you all in the Europe time zone. I'm welcoming you at the Intermittent Auskultation webinar with Dr. Small, obstetrician and researcher from Australia. And I hope that you will enjoy the presentation. That's going to take about 60 minutes. And after that, we are going to hold questions and answers for you. So enjoy. Thank you.
Thank you for the introduction, Linka. So I am from Australia. Specifically, I'm from about where the arrow is there. So I'm on the Sunshine Coast in Queensland, on the eastern coast of Australia. The traditional owners of this land are the Gubbi Gubbi Aboriginal people of the area, and as I always do, I begin by paying my respects to Aboriginal elders past and present, and acknowledge that there was a long tradition of birthing on this country and traditional knowledge around women's care during pregnancy, labour and afterwards, and much of that knowledge was lost when Australia was colonised. As Lenka said, I trained as an obstetrician and gynaecologist, and I worked in clinical practice for most of my professional life. I retired a few years ago. I've also worked as a university educator, so I'm quite comfortable with providing education for people. And I have a PhD that was awarded in 2020, which specifically looked at central fetal monitoring. And in the lead up at time and the early years of the PhD, of course, one has to get across the evidence base for fetal monitoring. So I had the luxury of lots and lots of time to be able to start reading quite deeply into what the evidence said. And I went into it already with an understanding that much of what I had been taught as a junior doctor was not actually well supported in research, and I had underestimated the extent to which that was true. So I was constantly surprised as I was reading the original research, just how big the difference was between what I had been taught and what was actually there in the published literature. And so through the PhD and the years beyond, one of the things I've done is translate that research into easy to understand education for clinicians and for women who are using maternity services. And the easiest way for you to access that is my blog, which is birthsmalltalk.com, and I publish something there most weeks, and it's mostly always about fetal monitoring, though sometimes something else catches my eye and demands to be written. And usually I'll go through some recent research or summarise a collection of research about a specific topic so that people can easily access the information even if they don't have online library access to full text papers. Lenka met me as I was in the process of promoting the Fetal Monitoring Academy, which is my online education space, and it's a paid annual subscription to be able to join the Fetal Monitoring Academy. And it just so happens that enrolments are still open, but they will end on the 31st of August. So there's a window of opportunity if you are still interested in enrolling to come along and join us. And I'll share a little bit more about the Fetal Monitoring Academy before we get to the end of the presentation today. Now, the plan for what we're going to cover, Linka and I tossed around some ideas, and this is what we settled on. I'm going to talk about why I choose to talk about CTG use rather than use the term continuous electronic fetal monitoring. We're going to run through the evidence base that compares CTG use with intermittent auscultation, specifically during labour, and then I'll also, in the next section, talk about the use of admission CTGs when women first present for care during their labour. We'll then talk about why I think consent for fetal monitoring is such an important human rights issue, and it's an area that's been neglected often in conversations about transforming maternity services, and there's clear research evidence that we are not doing a great job in that space. And then for those of you who are in the Czech Republic particularly, or other areas in Europe, give you an opportunity to just have a glimpse of what's going on around the world in terms of other commonly used approaches to fetal monitoring during labour and during pregnancy. And we'll talk a little bit about what's in the guidelines from other countries. All right, so let me launch into this and start the conversation about what is fetal monitoring in the first place. So broadly speaking, it is any approach that is used to assess the well-being of the fetus, with the goal then of using that information to make decisions about care that might mean heightened levels of surveillance or some kind of treatment or earlier birth. I don't use the term continuous electronic fetal monitoring, and I do use the term CTG use instead. And there's 4 main reasons why I have a problem with continuous electronic fetal monitoring, and they relate to the word continuous, the word electronic, the word fetal, and the word monitoring. And let me explain that, because that probably sounds a little silly. And I'm going to start with electronic. At the time that CTG machines were first invented, the alternative approach to monitoring the fetal heart rate during labour was to use a stethoscope, a Pinard or a Deli or a Kelly or some other non-electronic device to listen to the heart rate. And so calling the new thing an electronic fetal monitor distinguished it from these other approaches to performing intermittent auscultation. And it was a great marketing ploy because, you know, electronic gadgets were all the rage through the 1960s, and people wanted electronic kitchens and electronic garage door openers and all sorts of things. So it worked quite well for marketing, but it doesn't really apply anymore because most people now use a handheld Doppler to do intermittent auscultation. And that uses electricity to monitor the fetus. So it is a form of electronic fetal monitoring. And so is ultrasound, even though we're not necessarily looking at the fetal heart rate when we're using ultrasound. So that E bit doesn't really apply anymore. The fetal bit, yes, the purpose here is to improve fetal outcomes. But of course, a CTG is a cardiotocograph. It monitors the heart rate, but it also monitors the woman's uterine activity. So we're actually monitoring more than just the fetus here. Some of the information is also about what's happening for the mother. And there's a long history of women's role in their own births being written out of the story, and their wishes, desires, plans and decisions often are ignored during labour. And so by talking about CTGs and keeping the T in there, I like to think I'm going some tiny little way towards making sure that women don't become invisible when it comes to discussions around fetal monitoring. The other reason I don't use electronic fetal monitoring is the word monitoring. And by calling it an electronic fetal monitor, it implies that when it's attached to the woman and it is turned on, that monitoring is happening. But monitoring is a human activity. It's not something the machine does for you. A CTG machine produces a graph, so hence the name cardiotocograph. It produces a recording, or people will talk about it as a trace. It doesn't actually monitor. You need somebody who is trained to be able to read the quality of that trace, to interpret and understand what it is meaning, who has the authority to take action on it. So you could have a student who understands how to interpret it, but they don't have the right to say, we need to do a cesarean section. So they're not actually monitoring. And who has both the skills and the ability to then take action on the results of that. And throughout my professional life, and certainly once I moved into the PhD space, I have encountered lots and lots of stories of situations where a woman had been put onto a CTG machine, a recording was being generated, and no one came and looked at it. And as a result, there was a CTG tracing which beautifully illustrated what it looks like when a baby dies. And of course, if there is no monitoring happening, it's a bit inappropriate then to call what's going on monitoring. And you know, I can't talk about electronic fetal monitoring using that term and then explain that it's not actually monitoring, because the term has that implied in it. So at least with the CTG, I can talk about CTG recordings and use rather than actually monitoring. Linguistically, when we look at the language, of course, calling it electronic fetal monitoring has created a bit of a problem, and that is when women choose not to use a CTG, but instead to use intermittent auscultation for their labour. People then say, oh, she's not having any monitoring. But in fact, she is. She's having intermittent auscultation, which is a form of fetal monitoring. And as you'll see when we move into the evidence base, it's a very effective, safe approach to use. But the gut reaction of hearing, well, she's not having any monitoring is, oh, Lord, that's dangerous. We can't have that. And you see, when you look back at the research, by the 1970s, people are reporting on research studies saying that this was the group that had monitoring and this was the group that had no monitoring, when in fact what was going on was that midwives were using intermittent auscultation in the group that was said to have no monitoring. So we do need to be careful about the language that we're using. Now the final bit of this is the C, the continuous. Even when CTGs are in use, and even if you're using something like a fetal scalp electrode, you might generate a recording that is continuous, though more commonly there's still breaks and gaps and missed heartbeats from time to time. But the monitoring always remains intermittent. It is physically impossible for one person to continuously look at the CTG output for the entire duration of a woman's labour without ever blinking or glancing away or having to attend to something else in the room. So the electronic fetal monitoring is always intermittent, even if the recording is continuous. And depending on people's work situation, how busy their unit is, how many women are requiring care at the same time, whether there's a central fetal monitoring system in not, it may be quite some time in between episodes where somebody's actually looking at the CTG trace to tell what's going on. So the difference between intermittent auscultation and so-called continuous electronic fetal monitoring might actually be less than we imagine, because people may not actually be focusing their attention on the heart rate any more often than is happening when they're performing intermittent auscultation. Now, there are three main options for heart rate monitoring during labour, and one is to do none at all. One is to do intermittent auscultation, and as I said, most people in high-income countries are now using a handheld Doppler, and mostly with a screen that generates a number so that you don't have to sit there and listen to the sound and look at a watch and manually count up. Some people are also, or instead, using something like a Pinard stethoscope. There's our CTG machine. This is an external monitoring with a standard approach that's connected to the machine via wires. There are also telemetry or wireless options that allow the woman to not be physically attached to the machine. And I'm sure you're aware there are also internal options with fetal spiral electrodes and intrauterine pressure catheters, and there can be various different combinations of those that are used. There has never been a randomised controlled trial of any description that has compared not using any form of fetal heart rate monitoring with either intermittent auscultation or with CTG monitoring. So we suspect that some kind of heart rate monitoring generates useful information that does help us to make good decisions and to expedite birth in situations where there is concern for the well-being of the fetus. But we can't actually prove that, because the time at which intermittent auscultation was introduced in practice, which was about 1830, we were not in the same space as we are today when it came to evaluating the implementation of new technology. So the randomized control trial did not exist. And so people just simply started doing it and going, well, this seems like a good idea, and it entered practice. At the time that the cardiotocograph was introduced in the late 1960s, we did know better, and we knew how to do randomized control trials, but there was still quite widespread introduction of CTG machines before 1976, when the first randomized control trial was published. And the authors of that trial commented about the difficulty they had getting ethical approval for it, because already people had assumed that CTGs must be working, and therefore it would be unethical to randomise people to have intermittent auscultation and therefore to do the research. And so again, we see this introduction into clinical practice of a new technology without adequate examination as to whether it actually achieves what's being expected of it. And as you'll see shortly, as a consequence, we now have this well-embedded practice that modern maternity systems are built around, but it doesn't actually line up with what the evidence says. Which brings me to this. So let's have a look at what's going on when it comes to the evidence. How would you go about proving which is better, CTG use or using intermittent auscultation? Well, you could go to look at groups of women who had used a CTG and compare them with groups of women who had used intermittent auscultation, but it's likely that the reasons that people were using a CTG or were using intermittent auscultation in themselves will be associated with the outcomes of those births. And so what you will see is the difference between the reasons why it was being used and not the impact of the technology itself. There have also been, and there's plenty of those kind of studies around, there have also been some better studies, and I'll talk a little bit about those later, where again, it's retrospective observation, but they have then carefully mathematically controlled for those other variables that might be producing a difference in the results to see which one is the better approach. Because the best idea is to use a randomized control trial where people are enter the research and then are randomly assigned in roughly equal numbers to have either intermittent auscultation or CTG use. And these have been done, and not only have they been done, we now have what is considered the gold standard, which is to bring all of those randomized control trials together and subject them to meta-analysis so that we end up with one single answer to the question of whether CTGs or intermittent auscultation are associated with better or worse outcomes. And that has been published as a Cochrane review. It's Alfirovic 2017, and I will have a mechanism when we get to the end of the presentation for you to get a list of all of the reference material that I have used in this presentation, and it has hyperlinks in it so you can get straight to each of these papers. This one, in some countries, it's behind a paywall. You can get to the abstract but not the full thing. Here in Australia, our government pays for access so we can get full access to it. Some of the others are in journals that require a subscription, but again, you should be able to get to the abstract, and some of them are full text for free, so you can actually see the whole thing. So the Cochrane review has all up 13 randomized controlled trials. 11 of them, and they're the ones that we're going to look at today, compare CTG use with intermittent auscultation. One compared using more CTGs with using less CTGs. They had some months where they locked most of the CTGs that lived in that hospital in a cupboard and people were not allowed to use them, and months where they were all available for use. And one of the studies compared continuous CTG use with intermittent CTG use, not intermittent auscultation. A CTG tracing was being recorded, but it was done for a short period and then taken off again and returned again at a later stage. Now, if we focus just on the ones that look at continuous CTG use versus intermittent auscultation, the first of these was done in 1976. Most of the studies were done during the 1980s when I was a medical student, and the most recent was in 2006. So we're coming up for 20 years since the last contribution to this body of research. So yes, it is a little dated. Many places around the world have contributed to it. Some countries in Europe, Australia had 2 studies, some from the US, from UK and Ireland as well, and some from more developing nations. Now, one of the common myths I hear when people talk about the research that sits behind CTG use is that, oh yeah, but the Cochrane Review only talks about trials that included low-risk women. It doesn't include the research that looks at women who had risk factors, and that's actually false. Only 2 of those 11 studies came from exclusively low-risk populations. Some of the others were mixed risk populations, and they did separate analyses according to whether the woman was high or low risk, and the rest of them were from high-risk populations. So the bulk of the data that we have in the Cochrane Review actually relates to women who are considered to be at high risk. There we go. I forgot that I'd included that. So there's the 2 low-risk trials: UK, Sheffield, 1978, Melbourne, 1981. These are the ones that were in exclusively high-risk populations, and then these are the other 4 that have either a mixed population, or the authors didn't say whether it was a low or a high-risk population, and the Dublin trial includes data for a separate subset. The evidence is old and poor quality. That's true, it is old, and some of the studies, there was one in particular that was done in Athens. It looks like there was some serious problems with their randomisation being breached because the numbers were very uneven, particularly when it came to women whose labour was being induced, who almost all randomly ended up with CTG use, and very rarely ended up randomly ending up with intermittent auscultation. And they were literally using a coin toss, where it is very easy to go, oh, I don't like that option, and just flick the coin again until you get the option that you want, and to cheat on the randomisation. So yeah, not ideal quality, but it is the best that we have. And I often see people using this argument to justify that, well, CTGs must work because the evidence is old and poor quality. But of course, those statements don't belong together. You can't prove that something works with poor quality research. You can't prove that it's true or not at all. So it certainly doesn't support an argument in favour of CTG monitoring being the superior option. So let's hold our horses and dig into what the evidence says. And as I mentioned at the beginning, as an obstetrician, I was somewhat taken aback when I started digging into this and going, that can't be right. That's so not what I was taught. So just be prepared for the fact that you too may have that kind of a response as we move into this research. So first we'll go through outcomes for the baby. Now, the Cochrane Review only includes perinatal mortality. I've gone back to the original papers and have separately pulled out data for stillbirths and for early neonatal deaths, because I often hear people say that, sure, it doesn't make a difference to death rates overall, but it actually prevents stillbirth, and it's actually not the case. So there is no significant difference in stillbirths between the groups who were randomised to CTG use or intermittent auscultation. There's no difference in early neonatal deaths, and there's no difference overall in perinatal mortality. And we've got fairly good numbers in terms of sizes here, with more than 33,000 births in these research studies. So you cannot generate an argument that CTG monitoring saves lives, because that's not what the research shows. The only area where there appears to be a benefit is for neonatal seizures. The numbers here are still quite good, slightly fewer trials, but still 32,000 births. And with CTG use, the rate of seizures was 15 per 10,000, and it fell by 15 to end up at to get there from 30 per 10,000 when intermittent auscultation was in use. So a 50% reduction, that is statistically significant. The other way to look at that, if you're looking at it in terms of the numbers needed to treat, you would need to use CTG monitoring for 667 women to prevent one baby from having a neonatal seizure. So yes, it's a statistically significant reduction, but you need quite a lot of CTG monitoring to make a difference for one person. And I'll explain later, there's a bit more detail around the neonatal seizures information that makes me wonder whether this is still relevant today. Only one small trial has looked at hypoxic ischemic encephalopathy, and the difference here is actually one baby versus two babies. It looks like a huge difference numerically by the time I've multiplied it up to get it to out of 10,000, but there was no statistically significant difference here. And it's quite surprising that neurological outcomes have not been particularly well studied at all. The other thing that's not on this slide, but I will talk about here and a bit later on, is cerebral palsy. And only 2 studies have looked at cerebral palsy in terms of as a long-term outcome. And overall, there was no statistically significant difference. There was a slightly higher rate of cerebral palsy in the group who had had CTG monitoring. And in one of the 2 trials, that actually was statistically significant. So more babies were born with cerebral palsy in the CTG arm of the trial than with intermittent auscultation, which is counterintuitive and not at all what we've been taught. What about outcomes for the women? So there is a consistent increase in the caesarean section rate, a consistent increase in the use of forceps and vacuum extraction, and as a consequence, a consistent reduction in the spontaneous vaginal birth rate. Now, the caesarean section rate is extremely different to what we see in modern practice today. So it is starting from a much lower starting point than we would normally see, and instrumental births, depending on which part of the world you're in, either the same or slightly lower, and our spontaneous vaginal birth rate is now much lower than that. I often hear people say that having a CTG on makes labour longer and more painful, and there's not actually any evidence to support that. There's no difference in epidural use or in other forms of pharmacological analgesia. There's not good research that looks at labour duration, but as a stand-in measure for that, the use of oxytocin after the monitoring was begun, not for induction of labour, is actually not different between the 2 arms. And you would expect that if CTGs had slowed labour down, then more people would have their labour augmented with oxytocin to try and address that. So women definitely do worse when it comes to the use of CTG monitoring, not just in terms of not getting the kind of birth that they wanted, but each of these surgical birth approaches, of course, increases the risk of complications for both the woman and for her infant, from things like bleeding, infection, feeding problems for the baby, jaundice for the baby, deep venous thrombosis, pelvic floor trauma from instrumental birth. So they're not an insignificant intervention in women's lives. So I hinted at this before, that people often think the stuff that's in the Cochrane Review is about low-risk women, not high-risk women. And they then want to, well, you know, that's all very well and good, but, you know, surely it must work for some people, because that's how it gets used in most of the world. It gets used predominantly for women considered high risk. And so the Cochrane Review actually does break the findings down according to the risk category for the research. But there's some problems with that. And so before I show you those results, I want to preface this with, be prepared for the fact that the quality of this research is a great big pile of trash. And so I wouldn't necessarily read too much into it. The first reason for saying that is that the things that were considered as risk factors at the time the research was done are not the same things that are considered as risk factors today. So, for example, this low-risk trial, Sheffield 1978, 50% of the women in that study had an oxytocin infusion. That would now be considered as a risk factor, and those women would be very strongly advised to have CTG monitoring. It also included women who had epidurals, women who had meconium staining of the liquor, and women who developed a fever during their labour. Again, all of those are now considered to increase a woman's risk. So that this was not actually a low-risk trial as a consequence. Some of the risk factors are no longer relevant. So, for example, urinary estriol levels are not being measured, and they once were. And now instead we're doing things like measuring PAP-A levels or soluble FLT1 and doing risk screening for preeclampsia and including those women as high risk. But none of those trials have ever done that. The way that we go about diagnosing gestational diabetes has changed over time. So women who are now classified as having gestational diabetes would not have been considered as having gestational diabetes. So you can't neatly take the risk, the high risk, low risk division that was used at the time and say that applies to the group of women who are now either high risk or low risk in today's research. The other reason I think it's a great big pile of trash and we should be very careful about using it is illustrated by this table, which is a selection of some of the papers from the trial, from the Cochrane Review, and I've listed them in order from the one that had the lowest overall perinatal mortality rate up to the one that had the highest. And I haven't put all of the papers in here, but the two lowest are there and the two highest, and then two of the ones in the middle. And sure, the Melbourne low-risk trial really was, these women were at the lowest risk. It had the lowest perinatal mortality rate of all of the 11 trials at only 11. And the Sheffield trial was a little bit higher than that and was labelled low risk, despite the fact that, as I said, at least half of the women in that trial would not be considered to be at low risk by today's standard. But then we've got the Denver trial that also had a perinatal mortality rate of 20, but it was a high-risk trial. And the Dublin trial was a mixed-risk trial with a perinatal mortality rate of 22. So it's possible to have exactly the same perinatal mortality rate and be considered low-risk, high-risk, or somewhere in between the two. So at the time, people's ability to determine whether the population they were studying really were high risk or low risk was quite poor. And I don't believe we've actually gotten much better at that today. I think that we still have a kind of vague feeling in our gut about whether a situation is risky or not that doesn't necessarily match numerically with the reality of the situation. Now, having warned you that this may not necessarily be something that you want to rely on, this is what it looks like when you split it down. So for the low risk population, there was no difference in perinatal mortality. The same in the mixed and unknown risk population, and it is the same in the high risk population. So we're not doing better in terms of saving lives when CTGs are used predominantly for women considered to be at high risk. In the low-risk population, there's been no research about cerebral palsy. We don't know whether it's better or worse. No one's ever studied it, which is a big deficiency. In the mixed and unknown risk population, this is the Dublin trial, there was no difference in cerebral palsy rates. But in the high-risk population, and this was exclusively a population who of women who were all in preterm labour, they had one risk factor and that was it. The cerebral palsy rate was 1,950 in the CTG monitoring group and 760 in the intermittent auscultation group, so 2.5 times higher, and it was a statistically significant rise as out of 10,000. The neonatal seizures we see in the low-risk population, the rate is lower in both groups than it was in the overall data that I've presented before, and the difference here is statistically significant in favour of CTG use. The same applies in the mixed and unknown risk population, but in the high risk population, where we would normally think that you're going to get the most benefit, there in fact was no difference in neonatal seizures. When we look at the impact on mode of birth, it jumps about a little bit. So in the low risk population, caesareans but not instrumental births are higher, and that's the same in the high risk population. In the mixed risk population, it was the other way around. It was instrumental births but not caesarean sections. When you add these two things together and call it surgical birth, it's a statistically significant increase across all three categories. So CTG use always increases intervention for women, regardless of which risk category they belong to. So in many parts of the world, including here in Australia, the guideline recommendations are that women who are considered to be low risk should be advised to have intermittent auscultation, and women who are considered to be high risk should have CTG use. But that isn't the way that the evidence base actually lands, and there's no really clear distinction between benefit and harm in those two populations. Now, there are 3 trials, one of which I've just briefly mentioned, that are called what I call single risk trials. Most of the high risk trials included women who had any one of a large number of indications. So they had an abnormal heart rate on intermittent auscultation when they presented for care. They had meconium stained liquor, they were overdue, they were premature, they had twins, they had high blood pressure, they had gestational diabetes, they had some bleeding, they'd had a previous stillbirth, lots of reasons. So they all ended up in together, but there's no subgroup analysis. So you can't tell, for example, whether women with twins do better with CTG monitoring, and maybe women with meconium stained liquor do worse. Maybe when you put the two of them in the same trial, it cancels each other out. We don't know. So having some single risk trials helps, and they're really useful when it comes to counselling women, because when you have somebody, as I did once, with a twin pregnancy turn up going, I don't know that I want this CTG monitoring. What's the evidence that it works for women with twins? Well, there is no evidence. No one's looked at that in a single trial, even though in the Dublin trial, some women with multiple pregnancies were included, but there's no separate analysis of outcomes for them, so we don't know. The areas where we do have some specific information are vaginal birth after caesarean section. This is the most recent of the trials, done in India. Only 100 women, vastly undersized, so not capable of telling any difference in anything anyway, and not surprisingly, there were no statistically significant differences in any of the outcomes that they studied. There's an unpublished trial from Pakistan in 1989, which is reported inside the Cochrane Review, so you can get to the numbers even if you can't read the paper itself. And all of the women in this trial had meconium stained liquor. Again, small, it's only 200 women. No difference in mortality rate, but they did see a higher caesarean section rate. And then there's the preterm birth trial that I mentioned before. They had 246 women, 137 of those babies were then followed up until they were 2 years of age. No differences in mortality, in seizures or caesarean section, but there was the higher cerebral palsy rate. So far we're not seeing huge body of evidence that shows that CTG monitoring is fabulous and wonderful, apart from the evidence about neonatal seizures. And so I do want to stop for a minute and look a little bit more deeply at that body of evidence, because and I think it's legitimate to do that, because if neonatal seizures are meant to be caused by the same pathological process that also causes hypoxic ischemic encephalopathy or neonatal encephalopathy, whatever term you prefer, if it's the same process that also causes cerebral palsy, and if it's the same process that leads to death, then we should see these things all move in the same kind of direction in the research studies, even if they don't quite reach statistical significance. That should generally favour CTG use, and that is in fact not what happens with the results at all. Now, if the bulk of the data about neonatal seizures comes from the Dublin trial, McDonald 1985, because it was the largest of the randomised control trials that was ever done. Dublin was the home of the active management of labour protocol, so they were early adopters of very liberal oxytocin use compared to many other centres in the world. So they had quite high rates of oxytocin use in the trial, with 23% of women who were in the trial being augmented with oxytocin. They had a very low induction rate because they didn't believe in induction of labour, which is fascinating compared to today's modern practice. And it was, I think it was about 3% for induction of labour. But out of the 23% of women who had oxytocin, when we look at the number of babies who had seizures, it was actually 59% of the babies had been exposed to oxytocin during labour. So we get a glimpse here that oxytocin is not good when it comes to perinatal neurological outcomes. There is some data that is hidden in two tables in the trial that when you combine the two and do a bit of research maths, you're able to produce this particular table. And so what we've got here is the women who either did not have or did have oxytocin use during their labour, who were then randomised either to CTG use or intermittent auscultation. And when there was no oxytocin in use, the rate of seizures is identical. It was 15 per 10,000 in both the CTG group and the intermittent auscultation of the trial. So while this is not a subgroup analysis, so it's, you know, not as good as a randomised controlled trial specifically setting out to answer this question, it does give us a glimpse into the fact that maybe only a certain group of women benefit from CTG use. And when oxytocin was in use, we see a very big difference here. So 160 babies per 10,000 having neonatal seizures, and it fell to 36 in the CTG monitoring group. And I haven't put the statistics here, but this is a statistically significant difference. Because the other thing that's noteworthy here is the difference between this and this, that when you start oxytocin, even if you are using what is considered to be the superior form of fetal monitoring, you're not completely preventing the rise in poor outcomes that happens with oxytocin use. So it's a reminder that we need to be very cautious with oxytocin use. And of course, the world has changed since 1985 when this trial was being done in very many different ways. There was a paper published by Garcia et al. In 1984 that comes from the same study, and they were reporting on women's experiences of the different approaches to fetal monitoring. And in that paper, they explain the way that women were being cared for. And the primary care provider for women in the Dublin trial was mostly either a midwifery student or a medical student. So these women who are on an oxytocin fusion are having their care managed by a student, not by a registered health professional. And it predates the invention of infusion pumps. So the oxytocin was being managed manually with a giving set where you'd have to roll the little stop cup up and down and count the number of drops per chamber, through the chamber per minute. Now that would be considered outrageously unsafe in today's era. Or I've never worked in a place that would have allowed that. You always have to have an infusion pump delivering a set number of mils per hour because the overdosing of oxytocin is recognised to be so dangerous. And you would not leave a student alone and unsupervised to manage that process on their own. And so some of that in itself may explain the difference in outcomes here, that maybe with the CTG you could see what the contraction pattern was better than when the student was manually palpating them, so that when the midwife in charge came and did their rounds, they could say, oh, that's too many contractions, you should slow that oxytocin down a little bit. And maybe that's what the difference is here. The overall standard of obstetric care has just improved across the board since the mid-1980s. And so I went and pulled out the recent study, not Affirm, I'm going to have a mental blank now, US-based study looking at induction of labour at 39 weeks for women in their first pregnancy versus waiting. In fact, it was just later induction for most of the women. And the rate of neonatal seizures in their population, who all had CTG monitoring and who presumably all had oxytocin because they were in the early induction group. The number in this box was 4 per 10,000. So clearly, as we've now moved into the 2020s, the outcomes of maternity care are different. So I suspect that this evidence about neonatal seizures no longer applies in practice, and if it ever did, it probably only related to women who were using an oxytocin infusion rather than every woman. So, as you can see, there's not really any compelling research that shows that CTG monitoring is the superior approach to fetal monitoring. And I know in the professional guidelines here in Australia that existed at the time I did my PhD, they had this little phrase which I called the little hand wave. Yeah, that might not be true, but there's all this other research that actually says that CTGs work. Interestingly, the citation that they then gave for that, one of them was a randomized controlled trial. So it wasn't another kind of research, it was one of the studies that was in the Cochrane Review, and it was the one that had all of the problems with breaches of randomization. And the other one was a methodological paper about Bayesian analysis, saying that if you used a Bayesian approach, then maybe you might get different results. So not really compelling evidence. So one of the first things I did in my PhD was to go looking for all of this other research and pull it together and published a systematic review. And so that's this paper that we published in 2020. So we found, well, obviously we found all of the randomized controlled trials. We found 26 other studies that used an approach other than a randomized controlled trial. We focused on populations of women considered to be at high risk. And those studies spanned 1970 through to as recent as 2018, so something that's quite up to date. We used a tool called the Robbins Eye tool that assesses the risk of bias in non-intervention research, and 21 of those 26 studies were considered to be at critical or serious risk of bias, and according to the tool, you should therefore not rely on those studies to base your clinical practice on. Of the remaining 5, none of them showed any better outcomes when it came to perinatal mortality, and they didn't report on neurological outcomes, so we have no better data. So it isn't true, when we're looking at populations of women considered to be at higher risk, that there is a big body of evidence out there that shows that CTGs work. In fact, it's quite the opposite. What we have shows that CTG monitoring is no better than intermittent auscultation. There's also a study that was published in 2019 that came out of the USA, Lisa Hill and Fancher, and they looked at a very large data set of births from, I think it was California, that included just over 1 million women, and theirs was focused on low risk at the time of labour onset. Some of the women developed higher risk factors during the course of the labour. They also found no better perinatal outcomes in their research, and again confirmed an increased caesarean section rate. So that is, even though the caesarean section rate is now many-fold higher than it was at the time of the original studies were done, using CTG monitoring still seems to be producing that impact on the findings of the results in modern studies. So the best overall summary that I can then give, looking at all of that research when you put it together, is that CTGs actually don't work. They're harming women through increased intervention rates, and maybe they're harming some babies partly because of the increased intervention rates, more babies being born by caesarean section, forceps or vacuum, and developing complications related to that mode of birth. And there's still this ongoing unanswered question about, what about babies in preterm labour? Is CTG monitoring somehow or other making things worse for them? Because nobody's ever gone back to address that question, even though that was raised in the 1980s. Recently, I have flipped that around to saying this, and I think the impact of it lands quite differently. And that is to say, intermittent auscultation is actually just as good as CTG is for babies, and maybe it might even be better. And it's definitely better for women when we use intermittent auscultation. And as I said at the beginning of this section, that may be very different to what you've been taught as a maternity professional through the course of your training, but it is the way that I see the evidence landing. And again, as promised, there will be a way for you to get all of the references to all of these papers and the ones that are yet to come, because I encourage you to go and have a look at the evidence base for yourself and know that I'm not just making things up. It really is the way that it looks. So my belief then is that rather than splitting women up into low risk and high risk categories and offering them different approaches to fetal heart rate monitoring, what we should be doing is discussing all of the different options for fetal heart rate monitoring with women, their pros and cons, what's available locally, your personal expertise with one or the other, and allowing women to decide for themselves which choice they would like to use. And of course, their decision may change as labour unfolds and as they experience a form of fetal heart rate monitoring and go, oh, this isn't what I was expecting. I think I'll have that other one. Thank you very much. And we're quite some way away from this being achievable. It's certainly not common practice that women are given information and choice. So now I popped this here to remind everyone that we will be having a Q&A session. There is an area in your Google Meetup screen for questions, and you might like to start thinking about some of them and possibly even tossing them in that area, and we'll get to those when I get to the end of the presentation. So a quick little coverage of admission CTG use. Now the philosophy behind admission CTG use is that it's used for women who are considered to be at low risk, because women who are considered to be at high risk are advised to have CTG monitoring instead. And it's designed to try and identify a population of women who might otherwise have intermittent auscultation during their labour, so that they instead can have some continuous CTG monitoring on the basis that that will therefore improve outcomes. And so there's problem number one is, first of all, there's no evidence that switching these women over from intermittent auscultation to continuous CTG use could possibly improve outcomes, because there's no evidence that that works. Nonetheless, people have actually researched this, and so let's have a look at what they've found. So there's a Cochrane review here, and there are 4 trials. The research is 2001 to 2008, so more recent than the CTG versus intermittent auscultation stuff. So again, people knew at this stage that continuous CTG monitoring labour couldn't improve outcomes. So why they thought that trying to find more women to use a thing that was unproven would improve outcomes is kind of blows my mind. People were obviously very optimistic about CTG use in an inappropriately optimistic way. Just over 13,000 women, as I said, all of these were considered to be low risk at the time of presentation. And those 4 trials showed collectively no difference in perinatal mortality, seizures, or hypoxic ischemic encephalopathy. There was an increase in caesarean section and instrumental birth rate, and women who had an admission CTG were much more likely to continue on with a continuous CTG throughout their labour than the women who started with intermittent auscultation. Since then, there has been one more published trial that has not yet made it into the Cochrane review. So this is the ADCAR trial. This is Dublin again. 3,000 women, again, all low risk at the onset of labour. There were no deaths in the study, but all of the other perinatal outcomes that they looked at were not significantly different. Interestingly, there was no differences in caesarean section or instrumental birth. And when I have combined the previous meta-analysis and added this one and re-meta-analysed, and the overall, there are no improvements in perinatal outcomes, but the difference in caesarean section rate has now disappeared with the addition of this new data. And if you particularly wanted to see that meta-analysis, that's one of the reasons you need to join the Fetal Monitoring Academy, because that's where I put all of these special things for people that I do on top of the normal stuff that's available and published on the blog. So that brings us to this section, which is to remember that consent is a human rights issue. So the World Health Organization says that the right to health includes the right to control one's health and body and to be free from interference. Legal systems around the world recognize that people have the right to consent or withhold consent for any intervention that might be advised by a health practitioner, and that in order to consent, they need information about the potential benefits and risks that are associated with that intervention. And we do not do well when it comes to fetal monitoring at ensuring that we are either providing people with information or with a choice. And, you know, I think number one message that I like to send out into the world is this one, that fetal monitoring is your choice as the pregnant woman. We know that women want to be involved in decision making about fetal heart rate monitoring. So there was a study in the UK, and they surveyed women, and 97% of women wanted to be involved in the decision about which kind of fetal monitoring was being used. But we also know that women are not being given information. So that same study from the UK, only 40% of the women in that study said that they were given enough information to make a decision. In Australia, more recently, there's a study that shows that only 37% said that 37% said they were not given enough information, and another more recent study in 2024 flipped the other way around. Only 21% said they were given enough information. So the numbers are different from place to place and time to time, but it's never 100% of women saying, yes, I had great information about fetal monitoring options. And it should be 100% of women saying that they had enough information to be able to make this important decision. That is a decision that every woman who labours, we know in advance they're going to need to make, and so there's time to discuss it during the course of the pregnancy. And not only are people not being given enough information, there's evidence that CTG use is happening in a way that is not being consented to. So studies from Australia in 2022, we had 20% of women reporting CTG use without consent, and a more recent one that was published just last year, where only 36% of women reported having been asked for consent. So we've got more than 60% of women saying that their consent was not sought before a CTG was being put on. The UK, that same study I mentioned before, 94% of those women who wanted the 97% who wanted to have a choice, 94% of them were not given a choice of fetal monitoring method, and similar problems in the USA with and more of an issue if you are not white, with not being asked for your permission before CTG monitoring is being used. So I couldn't find anything from Europe. I think that question has not been asked because people don't want to know the answer to it. So if any of you are researchers and are interested in a project, it would be very interesting to see if the same problems are happening through European countries as well. All right, we've got just a few minutes left to quickly have a look at this. Now, my understanding is that for the Czech Republic, that CTG monitoring is used for basically every woman during her labour and birth. And I just wanted to show that that's not the way it's done in most of the world. So this is Australia, which obviously this is my home. I know these guidelines particularly well because I analysed them as part of my PhD. They're actually currently under review, and I've seen the new version of the guideline, but can't discuss that yet because it's still not publicly available and the process hasn't been completed. So this was 2019, and the guideline specifically says that women must be provided with information about their fetal monitoring options and have their decisions respected, so that they can ultimately choose which approach or none will be used. CTG use is recommended for women who have one or more risk factors, and intermittent auscultation is advised as the better option for women who are considered to be low risk. There is a recommendation about admission CTGs that permits their use if a clinician wishes to use an admission CTG, but the use is not actually recommended in light of the evidence base. So we have, from my understanding, we have more intermittent auscultation use here in Australia than you're seeing in the Czech Republic, but nowhere near as much as I would like to see. The hospital where I did my data collection was a very busy tertiary hospital that handled all of the high-risk cases for the region, and every time I went into birth suite to do a period of observation, I made a note of how many people had CTG monitoring versus how many people were in the birth suite at any one time. And it worked out as 90% of the women at this hospital were having CTG monitoring during their labour. So still quite a lot, but not everyone. This is just a collection of guidelines from around the world, and I've also, in the reference list, there's a paper that is a review of guidelines, so it summarises these and some others that I haven't included in the list as well. And the common approach with all of these is to do some kind of risk assessment and recommend intermittent auscultation for women who are considered to be at low risk, and recommend CTG monitoring for women considered to be at high risk. But they do broadly, and some of them do better than others, recommend that women are given adequate information and recognise that they have the option of having a choice. The physiological CTG interpretation one, the original version of this fails badly because it says that CTGs are mandatory in women who have risk factors, which is a huge human rights breach, because you cannot force a woman to have a CTG monitor if she does not consent to its use, and no guideline should suggest that people try and ensure that a woman has CTG monitoring if that's not what she wants to do. So if you did, as a group, wanted to get together and start looking at reformulating care guidelines, there are at least some examples internationally available, published, and fairly easy to get your hands on by a quick Google search, that could be the beginnings of a guideline revision to bring practice in the Czech Republic up into a similar area as what's happening around the world in other places. All right, so as promised, I said there would be a way for you to get a copy of the slides and references. And if you grab another device and scan that QR code, it will take you to a website that will ask for your name and your email address, so I can email you, ask you for a little bit of feedback about the presentation. There's also a box there where you can ask some questions. So if something's come up for you during the course of the presentation and you'd really like an answer to it, we're going to cover some of those in a moment, but you might want to email it to me as well, and I'll then get back to you, and I'll send, it'll automatically generate an email to send you out the slide deck from this presentation and that reference list. And as I said, I encourage you to go through it and have a look at the research yourself, and reassure yourself that what I've presented today is an accurate reflection of what that says. And Lenka has that she has that link, so I'm sure if you didn't manage to grab it now, she'd be happy to share it with you so that you can grab those things in another couple of days. They won't be there forever. I will have to take that web page down eventually, but it will be there for at least for a week or two. Now, as I said, the enrolments for the Fetal Monitoring Academy are open at the moment. This is my annual subscription. It contains a very large collection of resources about all sorts of things to do with fetal monitoring. So there's the evidence base, there's a big section on how to safely do intermittent auscultation. I'm working at the moment on a whole pile of new resources around physiology for fetal heart rate monitoring. There's admission CTGs and antenatal CTGs and fetal spiral electrodes, all put together in easy to understand language, and great, particularly if you don't have access to an academic library to get to the original research yourself, to have somebody who knows how to read and interpret research, explain it to you. And as I said, enrolments are open until the 31st. I only open twice a year, so I'll be in contact with a little bit more details about that if you do pop your name on that previous registration list. If you just want to hang out with me on social media, you'll find me on Facebook, Blue Sky and Instagram, and at Birth Small Talk is my the name of my blog, and it's also my username on those platforms, so feel free to go and follow and see what's going on over there in that area. And now I'm going to finish talking for a bit and have a little drink and hand back to Lenka, and we'll have a conversation instead to answer your questions and take any comments.
Thank you very much, Kirsten. It was a wonderful lecture and a compelling pile of research that is a little bit wobbly when it comes to the decision to do the CTG in the whole population as we now do without any other alternative choice. So I would now love to give our audience possibility to ask questions. So just please mute your microphone. We will enable your screen and enable your sound again after the presentation. And if you have a question, just please raise your hand and we're going to proceed like that. Is it okay? Yeah. So let's do the little bit of housekeeping, enabling the video. Right.
And for any of you who are a little bit worried about talking, feel free to type it in the Q&A box. And I'm sure if you prefer to do it in Czech, then you can ask in Czech and Lenka can translate it for me, because unfortunately I'm very limited in terms of my language options.
Happy to see some of you popping up on the screen. So, right. So don't be shy. We are here for you, so you can ask a question. So first volunteer from the audience with a question. If there is another question, I'm full of questions, so you can start with mine. Yeah. So if we don't have any volunteer to pose a question, my first question for you is how to support midwives in hospitals to start with intermittent auscultation in an environment where CTG is the norm.
Are your midwives also providing antenatal care to women?
Not really. It's a pilot thing here and there. And basically the situation is so that the care is provided by obstetricians only.
Because the best way to learn is to start using intermittent auscultation during your antenatal visits when you don't have the same pressures and multiple things going all at once, and the same the chance of an abnormality is of course extremely low in the antenatal setting, so that you can at least learn how to palpate the woman's abdomen, identify where the right place is to have a listen, and get comfortable with using whatever device you prefer to use. I think for midwives, because you can't necessarily rely on the hospital to provide you with good quality equipment to do intermittent auscultation, it is worth purchasing your own handheld Doppler and getting one that's waterproof, so you can take it into the shower if the woman's in the shower, and that does have a screen that displays the numbers, because it really does make it so much easier. In the same way you would look at the CTG monitor and it says the heart rate's 134, 138, 126. It does the same thing, so that you're not having to sit there and look at a clock on the other side of the room with postmenopausal eyes trying to work out when it's going tick, 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 and count to, potentially 170 over a 60-second period. That's not ideal. I think I'm going to come and join the Fetal Monitoring Academy, because I've got a great section, which is the recording from the workshop Lenka was at just the weekend before last, that takes you through specifically what to look out for when you are hearing the heart rate, how to document it, how to take action. And I think that the important lesson is that when it comes to interpreting and taking action, well, you already know what to do. It is the same heart rate, and the abnormalities that you were trying to detect are the same abnormalities that you would be trying to detect if you were using CTG monitoring, and your response should be the same when you are detecting those problems. So you need to listen long enough to be able to establish what the baseline is, and that may involve listening not just for 60 seconds in between contractions, which is what a lot of the guidelines say, but listening for an extended period over the course of 5 minutes through a contraction and out the other side, until you can work out when is that heart rate at baseline and what is that baseline. You can then assess variability, and that's tricky to do unless you actually have the numbers on a screen. But if you have them on a screen, then you can watch and see, you know, it goes from 125 to 136 over the course of the 60 seconds that I'm listening. So I know that there's 11 beats of variability, so that's reassuringly normal. Or it might just sit at 120, 121, 120, 122 across the entire 60 seconds that you're paying attention, and that would be reduced variability. You then want to know if there's accelerations. So ask the woman when she feels the baby moving and have a listen and see if you can hear the heart rate higher and then returning back down to normal. And of course, it's really important to determine whether there are decelerations present. And one of the areas where I differ from most people who teach intermittent auscultation is that I think you need to listen during contractions, and you need to do it reasonably often. Most guidelines say to listen either in between or maybe just at the end of a contraction. But I think you do need, obviously with the mother's permission, to listen through contractions from time to time and reassure yourself that either there are no obvious decelerations happening, or if there are, to understand how long the heart rate is down for and how low the heart rate goes and how long it takes for it to recover again. So exactly the same information that you would be looking to a CTG tracing to get, you can get from your intermittent auscultation. And as I said right at the very beginning, we tend to think, oh, but it's not continuous, I might miss something in the gaps. But then there are long periods of time where you're not looking at the CTG either. The only difference is that you can look back and fill in the gaps afterwards, because hopefully there's at least a continuous recording and not periods of loss of contact where the woman's moved and you haven't been recording anything, or you've been recording the mother's heart rate. And you don't necessarily need every single heartbeat in order to get enough information to make a decision. And there are a couple of studies. One of the paper that was in the Alfirovic-Cochrane review that looked at intermittent versus continuous CTG use. Admittedly, it was continuous CTG use versus intermittent CTG use, but they in the time periods where the CTG was not on continuously, they were using intermittent auscultation, and there was no period of time in that study where they had put a CTG back on and somebody went, oh no, we didn't realize there was a problem. If there was a problem detected during the return back to CTG monitoring, it had always been preceded by a midwife having detected a problem with intermittent auscultation. So you will probably very quickly learn to be quite good at it. And while you're learning, doing it intermittently is the appropriate thing to do. So, do it when the woman first arrives and then put the CTG on. If she's come off the CTG for a time period because she's been to use the bathroom, have a listen with your intermittent auscultation before you put the CTG on, while you're building up your skills and your confidence to know that, yes, I am hearing fetal heart rate. Yes, I can tell the different features of the heart rate and know what's going on. And of course, that then opens up new possibilities as well for being able to provide care outside of a hospital setting for you as well.
Yeah, it definitely does. But the major argument here lies in that we are no longer using continuous monitoring. We are using intermittent CTGs, as they call it. And it's centralized in many hospitals. And there is it's an alibi for a safety, like this is a safety measure. It's considered to be safety measure. But what I'm missing is the watchful attendance. Once you get out of the room and you're watching the monitor in your nursing station, with the centralized monitors from all the boxes or all the delivery wards. So is this the safety? Is this the safety? No, it's definitely not, because we're missing out the parts and we are not doing intermittent auscultation in between. So I really think that the situation now we have here is that we miss intermittent auscultation as a skill that should be at least done in the pauses between the intermittent CTGs. What do you think of that?
And there's an intimacy about intermittent auscultation that you don't quite get by putting a CTG on, and then particularly not if you're wandering out to the central monitoring station. You have to touch the woman's skin, so you'll know she's hot. I better check her temperature. You'll know that she looks dehydrated or not. You'll be able to smell that she's dehydrated and a bit ketotic. You can see her through a contraction and think, that pain seems ridiculous and she doesn't seem to be getting much break in between these contractions. What's going on here? You'll be able to smell if she's got chorioamnionitis and infected liquor. You'll be able to see if there's bleeding. All of that's not visible from the central monitoring station, and until you get to the point where the changes are now so significant that they're impacting on the heart rate, you'll miss all of those things. There has never been a randomized control trial that's examined the safety of central fetal monitoring, ever. It's just been assumed that it works. There have been 3.5 studies that have compared a period of time where CTG monitoring, where central monitoring was not in use, with a period where it was. In 3 of those studies, it was in a place where central monitoring had been a standard part of care, and then the system broke and they couldn't afford to place it right away, so they had a period where they didn't have it, and so somebody then went back and went, oh, here's a nice little study, and compared the before and after periods. And in those studies, there was no difference in perinatal outcomes, and in some of the studies, the caesarean section rate was higher when the central fetal monitoring system was in use. So higher again than the increase that you get just from using the CTGs in the first place. So, you know, it explains partly why all of our countries are seeing this vast rise in caesarean sections. The HARFA study is one that is going to be presented next month at the Normal Labour and Birth Conference in the UK, and it's work I was involved in as one of the authors from Iceland, where they they did it the other way around. They went from not having a central fetal monitoring station to having introduced it, and one of the midwives over there then looked at perinatal outcomes, and again there was no improvement with the introduction of central fetal monitoring. So there really is, there's no objective quantitative proof that it improves outcomes. My PhD was focused on central fetal monitoring, and at the hospital where I collected data, they had a very, very strong culture that you did not leave birth rooms even when the CTG was on, and their staffing, they had 3 midwives, they had 3 midwives for every 2 women who were in labour ward, so it was well staffed. So no one did leave birth rooms, at least not in the 90 odd hours I was hanging around watching people practicing. But even there were behaviours going on that made me think this isn't really safe, because often the people who made the decision about what to do were the obstetric registrar and the midwife who was in charge of the shift, who would stand in front of the central monitoring station and look at the CTG and decide she needs a Caesar, and then they would go to the birth room and tell the woman and the midwife, you're having a Caesar, and not say, what's happening in here? And they would miss all of the information that was coming from the birth room that you couldn't actually see on the CTG. And so there were lots of instances of people getting terribly upset in front of the central monitoring station and dashing up the corridor and slamming doors open and coming flying unannounced into rooms, only to discover that, in fact, the baby was on the woman's chest, and that's why it looked like there was a bradycardia. It had been born, or the woman was on the toilet. I had one instance where the registrar rang the midwife in the room and said, "You need to turn up the oxytocin because she's not having any contractions and I'm not having that." And in fact, what was happening was the woman hated the feeling of the belt around the upper part of her abdomen. So every time the contraction started, she would pull the toco away from her abdomen. So it just recorded a flat line, and she was having 4 in 10 contractions. So, fortunately that midwife was strong enough to say, "No, I'm not doing that." But the midwives all spoke about they were no longer asking for more medical care when they felt it was needed. In fact, what they were having to constantly do was say, no, things are fine. You need to leave the room and leave me alone and leave this woman alone, because there was this regular pressure coming from outside the room for more intervention, based just on what people were seeing on the CTG trace, which wasn't always accurately reflecting what was happening in the room. So yeah, I have some serious concerns about central fetal monitoring systems, and I really think we should take 3 very large steps backwards from them and go back to having people walk into rooms and look at the trace at the bedside and have to actually look at the woman at the same time.
Thank you. And what about the trend towards the more computerized way of analyzing CTGs, and together with the ST analysis, it should be, the wow effect that we are going to have miniature CTGs, we're gonna do them for longer periods of time, and we don't have wires anymore. What about this trend?
The shift to wireless and now to beltless CTG monitoring is like the desire to make it more acceptable and comfortable for women is appropriate. But again, we should evaluate the consequences of doing that. It must be about 2 years ago now, there was a hospital in Australia that was running a fundraiser for more telemetry CTGs, and that was claiming that that telemetry CTG monitoring had been proven to reduce the caesarean section rate. And so I got quite loud on social media and went, there is absolutely no proof that that is true at all. It's never been studied in research. We do not know. There's one little tiny observational study from the UK that simply looked at women who had had telemetry and women who had had standard wide CTG, who had very different reasons for choosing each of those options, and the caesarean section rate was higher in the group that had telemetry. Hardly proof that it's making things worse, but it's certainly not proof that it's making things better. Non-invasive fetal ECG, we've got a couple of studies from a group here in Australia that have shown that women prefer it and find it more comfortable, which is fabulous. But again, there's been no evaluation as to whether that translates to better outcomes for women or for babies at all. And my concern is, as we have seen with so many of the technologies around fetal monitoring, is that people think they're a great idea, so they get into practice, and then either they're never evaluated or eventually they're evaluated and we go, oh, didn't work, never mind, too late, let's just keep going. And we really do need to slow down and actually work out the impact of what it is that we're doing with people. Stan, I like the concept of STAM, and I must confess I'm slightly disappointed that it's not evaluating well. One of the unsolvable problems with fetal heart rate monitoring is that for it to work, you need to have a different heart rate pattern for my oxygen level is low, but I'm coping okay with that. And my oxygen level is low and I am no longer coping okay with that. And please, thank you very much. Would you get me out of here right now and give me some oxygen? There's actually no difference in the heart rate pattern between those two fetal states. And without that, we can't actually perfect any form of fetal heart rate monitoring, whether it's intermittent auscultation or CTG use. So we need some reliable biological marker that shows up at the point where the fetus goes from, look, the oxygen level's a bit low, but I'm okay, where it tips over into, no, this is not fine. And the change in the ST segment makes biological sense, because as oxygen levels inside the heart tissue fall, that's what happens. So we know that this is, the heart oxygen levels are now falling. We're now getting into this is a bit serious situation. And yet the research that's been done so far on ST segment analysis shows that it isn't improving perinatal outcomes, and that it's also not reducing the use of unnecessary cesarean sections. So it's not, women are still having cesarean sections for babies that didn't necessarily need to be born earlier either. I wonder whether, and I've never worked anywhere that had ST segment analysis, so I've never seen it up close and personal. I do wonder whether the reason we're not seeing a difference in the research is that the comparison is always between CTG monitoring on its own or CTG monitoring plus STAN. And I wonder whether, because we've all been brought up on CTGs and we've developed such an emotional response when you see an abnormal heart rate pattern, like, the hairs on the back of your neck stand up and your gut drops down 3 inches and it's like, oh no. That when you're getting that feeling and the ST segment analysis saying everything's fine, which one do you believe? And I do wonder if if the comparison was between CTG use versus intermittent auscultation plus STAN, whether we might be seeing different results. But yeah, no one's brave enough to do that particular research as yet. Computer analysis, of course, the first level of computer analysis, which is what most of the clinical systems that are around at the moment, is based on the belief that midwives are a bit stupid and can't be trusted to interpret a CTG, and so we'll get a computer to do it for us. Because at least the computer will be consistent every time. And we do know, whether it's midwives or obstetricians, all clinicians are bad at consistently saying this heart rate pattern is the same thing when you repeatedly test them over and over again. But of course, if you program the computer to recognise the same heart rate patterns that we've all been taught as being a problem, but those things actually don't tell the difference between a baby that's coping and a baby that's not coping, then it's pointless. It still isn't providing you with information about the thing that you really need to know in order to make good clinical decisions. The most recent round of research that's going on, though, is to use machine learning or artificial intelligence processes where they take huge databases of CTGs where the clinical outcome is known. And so you have a large group of babies who did poorly and a large group of babies who were completely healthy at birth. And then they let the computer have at the data and try to find things in the heart rate pattern that we humans are not detecting. So maybe there is a heart rate pattern that we have not yet worked out as humans that might be the pattern that actually solves the problem for us. And that would be lovely if it is true. But even if that's true, it creates a new problem then, because then what happens is you go into hospital and somebody attaches this machine, and at some point in the labour they wander in and go, oh, we're doing a caesarean section now. And you say, well, why is that? And they go, oh, because the computer said you need one. Yeah, but why is the computer saying that you need one? Oh, I don't know, I can't tell, but it just says that you do. That's a very profoundly different level of trust in the technology that's required to sign up for that and to commit to having the decision about how you're giving birth taken out of your hands, and the care providers can't actually explain what it is because they can't see the patterns. There's something that can only be seen by a computer. So yeah, time will tell. My intuition is that trying to find patterns in heart rates, it will never work because of the way that fetal heart rate physiology works, and then we'll have to go somewhere else for some other biological measure. There is some interesting research going on about transabdominal fetal pulse oximetry. So you could actually wear a device around your abdomen that monitors fetal oxygen levels directly, or placental oxygen levels, and that makes more sense to me. If you went to the emergency department and you were worried about somebody's oxygen levels and all they did was take your pulse, you'd probably write a letter of complaint. But if you go to the maternity unit saying, I'm worried my baby's oxygen levels are low and all they do is take your baby's heart rate, that's considered best practice. So being able to directly measure oxygen levels would be useful. There's some studies that are looking at a transcranial, so something you could put through the vagina and onto the fetal scalp device to measure brain oxygen levels in the fetus directly. There's some potential fetal blood tests measuring things like troponin and S100B, which are markers of either heart or brain injury. So we may yet have a better option technologically, but in the meantime, I think we can do as well with intermittent auscultation as we can with CTGs without creating the extra surgical births and that ultimately harm women and some of the babies.
Thank you for that. You summed it up perfectly. Just to wrap it up, we need to say that monitoring of fetal heart rate is just a piece of a puzzle, and that it shouldn't be taken for granted as a sign of distress or not distress, because it's just a piece of the observation and of the watchful attendance, and it should be like that. And I wanted to wholeheartedly thank you for your lecture and your time you have given us, and thank you to all the attendees. And if there are any follow-up questions, please use Kirsten's box or our email to pose a question afterwards. And I just wanted to tell you that there's going to be a subtitled version in let's say a month. I wouldn't promise something that I can't deliver. And everyone who's on the email list and who was in this session will get the link to the subtitled version. So thank you again. Enjoy the rest of your evening, Kirsten. And I hope that many people from this session will join the Fetal Monitoring Academy with you and go deeper into the intermittent auscultation. Yeah, thank you. Bye-bye.